Good afternoon and welcome to the United Nations, to our event, the United Nations Department of Global Communications Civil Society Unit meeting, HIV/AIDS, meeting unmet needs in treatment and prevention, organized in observation of World AIDS Day. I am your moderator for this afternoon. I am Ugoji Adanma Eze, CEO of Renew Our Earth, the main mission of which is to build back better pandemic prevention, preparedness, and response. I'd like to first and foremost welcome civil society audience who are here in person and watching online on UN Web TV and UN YouTube channel. I'd like to say a special thank you to the organizers in Civil Society Unit in the Department of Global Communications, led by Hawa Diallo, a huge thank you, with the support of Crystal, Frisella, Swati Dave, Stephanie Cardi, and our fabulous intern, Jessica Wren, and Catherine Chen, my personal assistant. I'd like to remind you to join this conversation online and use the hashtags, UN Civil Society and UN AIDS, World AIDS Day in your posts. Also, could you kindly follow the Civil Society Unit on Twitter, on Facebook, and on Instagram. All of the handles will be shown on the screen. Thank you very much. This event is intended to provide a platform for the exchange of views, sharing of experiences, and setting shared goals and indeed targets towards addressing the effects of meeting unmet needs in the treatment and prevention of HIV/AIDS and achieving the targets of the 2030 Agenda for Sustainable Development and Africa Agenda 2063, particularly those related to health. It now gives me a huge pleasure for opening remarks to hand the floor to Angela Akrekar, Deputy Executive Director of Program, branch of the Joint United Nations Programs on HIV/AIDS, UNAIDS, and Assistant Secretary General of the United Nations. Madame, the floor is yours.
Thank you so much, moderator. And let me first say what a pleasure, an honor it is to be here with you all today. And I also want to, before I begin, just say a personal note of gratitude and thanks to each and every one of you for it is civil society. It is community organizations that have led the way in the response over the decades. And it is you that we have to thank for the progress that we're starting to see. So it's a real pleasure to be here today to help commemorate World AIDS Day. As you all know, the world came together on Friday to really shine a light on the 39 million people that we're standing in solidarity with, that are living with HIV, but also to recognize and pay respect and honor to the 40.4 million lives that have been lost to the fight over these many years. World AIDS Day is also a time for us in a world that is seized with war and devastation and really difficult times. World AIDS Day is also a moment for us to reflect on the incredible progress that we've seen in the global HIV response. It is a moment where we and the work that you have done over the years tirelessly with your heart and souls, we can celebrate and honor the fact that AIDS deaths have plummeted by 70% since their peak in the early 2000s, that there are new records of new HIV infections at record lows that are now present because of the work that you've done. It's one of the greatest success stories that we've seen. Still without a vaccine or cure, countries, Botswana, Rwanda, Zimbabwe, Namibia, others are reaching their 95, 95, 95 targets early because of the incredible work that you all are doing across the world, country after country, community after community, bringing life-saving prevention and treatment services to those in need. It's no surprise that of all the 17 Sustainable Development Goals, that the one that we are focused on, SDG 3.3, is actually making progress. We may be one of the only goals that actually is achieved because of the incredible progress that has happened in the HIV response. Not only are we going to see and have been seeing incredible progress in HIV outcomes, but we're also seeing systems for health, community systems for health that have been strengthened, laboratory systems, surveillance systems, supply chain systems, healthcare workers, community health workers, all which, yes, are incredible for the HIV response, but also have helped bolster countries and strengthen countries' abilities to respond to COVID-19 and other health threats that may emerge in the future. But today, I also, while recognizing the incredible progress that's been made, I also want to reiterate that the job is not yet done. Every single minute, a life is lost because of AIDS. Every single week, 4,000 new infections are happening. 3,100 of those are happening on the continent of Africa. 9.2 million people are still in need of life-saving treatment. We cannot left them behind when we know we have the solution, we have life-saving treatment that is available. We have to be able to get it to those people in need. And as I noted, while we're seeing record lows on new infections, we still have 1.3 million new infections that are happening every year. We are leaving children behind, adolescent girls and young women behind, and key populations, LGBTQI+ populations behind. We have to continue the fight. The job is not yet done. But this is not our fate. We can change this. We know how to do it. You have shown us how we can lead the way. The path to end AIDS has been trailblazed by communities, by civil society organizations. You have led the way. That's why this past World AIDS Day, the theme has been Let Communities Lead, because you have shown us what is possible. You've shown us how to do it. And so we know that countries succeed when communities are placed front and center in leading the response. We've seen, for example, in Nigeria, when community organizations have helped administer treatment, life-saving treatment to the farthest flung communities, 64% increase in treatment coverage. That's extraordinary. That is the work and what's possible of communities. We've seen in Namibia, youth-led organizations that have creatively used e-bicycles to deliver care and support to young people that cannot go to the clinic because they're in school where they should be. So they're delivering services in very creative ways to reach young people. We've seen the power of the impossible in Ukraine. In war, it has been the community that has been there on the front lines, moving where the communities are, where the people are moving to ensure life-saving treatment does not falter and that people continue to have access to their life-saving medication. In war, that is the work of community. We've seen in South Africa, Thailand, and Brazil, we've seen the incredible grassroots movements that have been bubbled up from community organizations in the streets to the courtrooms with the parliamentarians, making sure that life-saving treatment is not only available, but accessible and affordable to the people that need it. We've seen costs of ARVs decline from $25,000 per person back at the height of the epidemic to $70 per person. And in countries now, they are free. In many countries, they are free. This is the work of community organizations. So today and every day, we leave you with a call to action. let's finish the fight. It's not yet done. So we have to mobilize to continue to bring life-saving treatment and prevention services to those in need. Second, let's continue to lift up communities. You have shown us what is possible. You've shown us how to do this work. And while civic space is shrinking and while human rights are being challenged every single day, it's really important to make sure that civil society and community organizations that can reach the populations more in need are supported, are resourced, and are protected in this work. And third, let's make sure that we are sustaining the incredible gains that we've made in the HIV response. We know they have not only helped on the HIV front, but they've also helped lay the foundation for COVID-19, other pandemics that will come now and in the future. So again, I just want to say thank you. Thank you for all the work that you've done and that you continue to do on behalf of the people we serve. Thank you.
Just like to say a huge thank you, Assistant Secretary General, for your leadership and for all you do. Thank you so much. It now gives me great pleasure to introduce or give a few minutes for each of the panelists, these amazing panelists, speakers, to briefly introduce yourselves.
Okay, all right, thank you so much, moderator Yoji. It's a great honor to be here with my esteemed colleagues on this panel. My name is Dr. Antonio Urbina. I am a professor of medicine at Mount Sinai Hospital. I've been working with people living with HIV since 1992, so for about 30 years. And since 2003, I've been involved in educating providers on pretty much the cutting edge for HIV treatment and prevention. So I'm very excited to be part of this panel and to discuss some of the really pressing unmet needs to really end this epidemic.
Emma?
Thank you so much for the honor of being here. My name is Dr. Emma Kaplan-Lewis. I am the Clinical Quality Director of HIV Services at New York City Health and Hospitals. I'm an infectious disease physician with a focus on HIV, and in my administrative role, provide support across our health system, which is New York City's municipal hospital system, for HIV treatment, prevention, as well as sexual health and viral hepatitis.
Mr. Fuller?
Thank you so much for this opportunity. My name is Dr. Folarami Ogunbowale. I'm a medical officer at the Division of Healthcare Management and Occupational Safety and Health at the United Nations Secretariat here in New York. I'm a public health specialist, and my work at the Secretariat revolves around ensuring access to HIV preventive services, including HIV PEP, in all UN duty stations globally, and also to support implementation of the HIV program in UN missions all over the world. With my years of experience on the field, I've interacted with patients, providing support in terms of HIV care. So I hope it's going to be a very fruitful discussion this afternoon. Thank you.
Thank you very much, Unit.
Good afternoon. It's a pleasure being here today. My name is Dr. Quentin Edwidge. I'm an HIV specialist, a PrEP and PEP specialist, a nurse practitioner. I work at the Federal Qualified Clinic providing healthcare needs to the patients of my community. It's been a challenge, addressing the unmet needs of HIV patients, but together as a community, we've been able to reach out to these people, and we've seen tremendous progress. Thank you.
Hello, my name is Raymond Ayala, Medical Case Manager at Brooklyn Path Center. My pronouns are he, him, and él en español. I've been in the field since 2005, and I'm happy to be here.
Great.
Okay. Good afternoon, everyone. My name is Toyin Falusin-Nwafo. I'm an infectious disease physician and professor of medicine, and I'm Senior Medical Director for HIV prevention at ViiV Healthcare. I've been in the work of HIV since 1995, working at Cook County Hospital in Chicago and Rush Medical for over 20 years, and then more recently with ViiV Healthcare. Really excited to be part of this panel as a physician, a clinician, a researcher, and an advocate, and really excited to be part of this panel today. Thank you.
And thank you all very much. I'd like to now put some questions, brief questions, to the esteemed panelists. I'd like to start firstly with Dr. Fuller. Do you mind?
Okay.
Okay. Dr. Fuller, what role can current policymakers play in creating an environment that supports effective HIV/AIDS prevention and treatment? Over to you, Doctor.
Thank you very much for this question. From what the ASG just mentioned earlier on, a lot has been done in terms of prevention, treatment, access for people living with HIV and people that are exposed to HIV globally. But we still have a lot of gaps that we need to cover. We still have a lot of things that needs to be done. And this is where the policymakers still play vital roles. We cannot say because of the gains that we have made that the policymakers should be taking the back seat. The policymakers still plays a lot of role in terms of HIV prevention, HIV treatment, access to HIV services globally. The first point I'll first of all address is access to health care. Policymakers must support and engage in ways to ensure equitable access to HIV-related services, and this should include things like testing, counseling, access to antiretroviral medication, and other essential health services. There are locations around the world. The services may be available, but availability of service doesn't equate to access to those services. So that is where policymakers still need to play a lot of role to ensure that people living with HIV, the people that are at risk of getting exposed to HIV, they all have access to equitable health services. So policymakers must support initiatives that support access to health services for HIV, people living with HIV. Also, there are locations around the world that this is the fourth decade that we have been dealing with this HIV epidemic. And you'll be surprised that there are locations that you can still not mention that you have HIV. There are locations that you cannot tell people that you are positive. There are locations that you cannot even tell your colleague in the office that, I'm somebody living with HIV. You may be discriminated against. So that is why policymakers must support legal framework that support individuals and other marginalized people or groups that are affected by HIV. Because even if we have good access to health services, we have the medications, but if people are being discriminated against, they will not access those services. That is why it is very, very crucial for policymakers to continue to support enacting legal framework that will support the plight of people living with HIV and people that are at risk and the marginalized group. And also, another thing that can be done by policymakers is to establish anti-discrimination law. It has been done in some locations, but despite that, some locations you still can't talk that you have HIV. So, which means we still have a lot of gap unmet in this area. And if we really want to end the epidemic of HIV by 2030, then policymakers, despite all that we have done, we still need to put in more effort. We still need to put in more energy to ensure that we have all it takes to end the epidemic. Also, another thing that is very, very crucial is community engagement and community empowerment. And, the theme of this year is actually taking us back to the community. The community can actually deal with a lot of things if they are empowered, if they have all the capabilities to mount the adequate response that are expected of them in terms of dealing with HIV epidemic. So policymakers can actually do a lot by ensuring that the community are recognized, they get all it takes in terms of building their capabilities, they have all the required resources that will make them to actually do their work in terms of mounting a formidable response to the HIV epidemic. And also, another area where the policymaker can also help is in resource allocation. If you look, since the beginning of the HIV epidemic, the funding level has been going down. It was like up, now we are going down. And you know, a lot of things can be used to explain this. We have a lot of other public health crises, public health emergencies, civil conflicts happening here and there. So politicians around the world, they have to rationalize where they want to spend the money. So policymakers still need to support allocation of resources to support treatment and allocation of resources to support prevention of HIV. So if you look, we are in the 4th decade now. We don't have a formidable vaccine to deal with this HIV epidemic. So though a lot of work has been done, so policymakers need to allocate resources to supporting like innovation, research and development to help the scientific world so that at least we can get some other preventive tools in addition to the vaccine for us to be able to fight this epidemic. I think
Yes, I think.
I can stop here, or if you want me to
Yes.
continue, I can.
No, if you can stop there. Thank you very much, Dr. Fuller, for basically highlighting. Thanks very much, Dr. Fuller, for basically highlighting the significant role that communities have to play in breaking down stigma of AIDS. If I may throw a question to Dr. Emma. Emma, how can healthcare systems better integrate HIV/AIDS services with other healthcare services to provide more holistic care? Are they successful models of integrated healthcare that address both HIV/AIDS and other health issues? Over to you, Emma.
Thank you so much. So, due to the incredible scientific advances that you've heard a bit about, and we'll probably hear more about, people with HIV can live a near normal life expectancy. People are no longer coming in, for the most part, dying of AIDS-related opportunistic infections or AIDS-defining malignancies. People are, in the context of living to older age, people are now developing chronic conditions related to older age, which on the one hand is incredible that people can live long, healthy, robust lives, but also has shifted the epidemic really towards one of multimorbidity, where people are aging with HIV, and not just in this country, but internationally as well, and are dealing with multiple other medical issues aside from HIV. So for example, frailty, neurocognitive decline, cardiovascular disease, age-related malignancy, diabetes, and these are just a few. So one of the most successful models that we have seen and implemented are having an HIV specialist that also is well-versed in all of these conditions related to growing older with HIV, all of these primary care-related comorbidities, and having both the HIV care as well as the HIV primary care and preventive care co-located in the same place, in the same clinic with the same medical team, so that the patient or the individual is not having to go multiple places for various different medical issues. They're able to be treated holistically in the location of their choice, where they can develop relationships longitudinally over time and feel cared for as a whole person, not just related to the HIV status. Another really important component is meeting people where they're at. This can be more metaphorical. For example, if somebody has distrust of the healthcare system, or if there's a language barrier and you're trying to overcome kind of what what gaps there are in terms of them being able to understand and access the care that they need, or this can be quite literal, somebody who is homebound and can't necessarily come into the clinic. And coming up with decentralized care models, for example, community health workers or case managers or care coordination, where people can be met in the community, in their homes, where not necessarily in the clinic site, so that the care is actually being brought literally to where patients are, so that to overcome the burdens or the barriers that they may face. And then I think lastly, in terms of integration, or not lastly, but before I hand it over to a colleague, really understanding the context in which people are living and are receiving care. So it's not a coincidence that there's areas with higher prevalence of HIV or worse HIV or other health-related outcomes. There are structural barriers in place, including poverty, racism, et cetera, just to name a few, that really impact people's ability to access high-quality care. And we as a healthcare community, it is our responsibility to dismantle these systems of oppression so people can access high-quality care that they deserve.
Thanks very much, Emma. Thank you, Dr. Emma. If I may ask a question to Mr. Raymond. May I call you Raymond?
Yes, you go, G.
What strategies are effective in reducing the stigma associated with HIV/AIDS, and how can these be implemented on a larger scale? And also, in what ways can healthcare providers and communities contribute to destigmatizing HIV/AIDS within their practices? Over to you, Raymond.
Thank you, Hugo G. So first, we have to start by honoring past struggles. We have to talk openly about then and now, differentiate myths from facts. There's some people still out there that say, oh, that is a gay disease, GRID. A lot of people don't know what GRID is or was back then. Gay-related immunodeficiency or diarrhea, where today it's HIV or AIDS. So we have to differentiate that. We have to focus on past mismanagements and step up our game when it comes to HIV and AIDS. From the 30 pills that were referred to as cocktails 20, 30 years ago to the bi-monthly injectable suspension. When the clients come in today and I'm dumbfounded, they're like, wow, can I get that option where I don't have to take pills and get pill fatigue? And I said, well, did you not know about these new medications that are there? No, we don't have that information. So it's very important that we break down stigma by having forums like this, putting them on TV, commercials, TikTok, Facebook, social media. And also, we have to show compassion. We have to be very empathetic to people. We have to respect many communities, Black, brown, yellow, LGBTQIA, and we have to start seeing people where they're at and showing compassion. Thank you.
Thank you, Raymond. If I may put a question to Edwiga.
Thank you.
What are the major challenges in addressing unmet needs in HIV/AIDS treatment and prevention? Are they specific populations or indeed regions facing more significant challenges? And how can these be addressed? Over to you.
Thank you very much for the question. They have been, as we had earlier, there's been a great progress in the management and prevention of HIV/AIDS, tremendous success, and that can be reflected in the decrease in mortality and morbidity, and also decrease in the new infections, which is really great, but there's still a lot that has to be done. And when we look at the challenges, the major challenges, the first thing is accessibility to care. You know, not only accessibility to care, but also affordability of care, because in some places there's this geographical disparity where some people actually have access to care but cannot afford the medication. And so that makes it very, very difficult, and that becomes a huge barrier. So taking care of that aspect would actually help as well. Another issue that actually is a huge challenge is actually stigmatization and discrimination. And this stigmatization it's not only limited to social stigmatization, it's also self-stigmatization. You know, most people diagnosed with HIV already face discrimination because of their diagnosis, you know. So it is very, very difficult if they actually encounter this stigma or this discrimination in healthcare system, they get deterred from actually accessing healthcare. So that is a huge challenge that we actually do encounter. The second thing is lack of awareness. Yes, HIV has been around for 40 years, that is true, but in some communities, in some parts of the world, HIV is still considered a myth, it's still considered a spiritual problem, you know, and some people do not even believe that HIV still exists. So actually creating educational sections like this and getting community involved and using social media to actually disseminate information, accurate information about HIV, you know, would actually help to prevent or take care of this challenge. And one most important one, actually, I have two more important ones. The first one is the healthcare infrastructure. We do have weakened healthcare infrastructures in some parts of the world, and even in the United States, most definitely. You can see that disparity in the South and in New York. New York has one of the best HIV prevention and management systems compared to down South, and you have the same problems in places like West Africa, Sub-Saharan Africa. So this makes it very, very difficult for people to access preventive care and also HIV management care. Talking about the second part of the question talks about the key populations. Of course, there are key populations. We have heard about them. You know, the most predominant are the men having sex with men. They face serious stigmatization and serious discrimination. That actually poses a huge problem as well. You know, we also have women. You know, so women also do face the same problems like men who have sex with men. The other community, people who in war-torn zones. We talked about Ukraine and people living in Africa that actually are in this war-torn zones already have a problem, you know, accessing HIV health care. And when we talk about geographical location, we know based on research and in real life that Sub-Saharan Africa has the highest prevalence of HIV/AIDS. And as the Assistant Secretary General said, 3,000 new infections in Africa, Sub-Saharan Africa. What is the problem? The main thing is access to care. Healthcare affordability. If this is addressed, then this will be taken care of. Funds are another ones. You know, there's financial constraints. Most of this government lack the financial capability to address this issue. So taking care of the financial, having the international organizations providing these funds will also help as well. And then we also have community involvement. It's very, very key. You know, we have to take into consideration the cultural background where these people come from and also the linguistic. So creating educational sessions and also seminars that take into consideration their cultural background will be key in addressing this issue. Thank you.
Thank you very much. Dr. Antonio, over to you. Beyond medical treatment, how can we enhance long-term care for individuals living with HIV/AIDS to improve their overall quality of life? What support systems in our communities are crucial for those who have been on long-term care treatment?
Thank you so much for that question. So as we know, patients are really living longer with HIV. So my oldest patient is 92 years old. And he has elevated blood pressure, elevated cholesterol, heart disease, diabetes. HIV is number 10 on his list of most active issues. So I think that that's a great advance. But I think we have to look at the unmet needs of all of the new infections, all those people that don't have access to treatment, and all those people that are not living well or aging with HIV. So I think education and awareness programs are essential. And that's a lot of the work that a lot of you do. But continued education about HIV and AIDS within aging communities is essential to reduce stigma and discrimination. And it can really help people get connected to prevention services, so HIV testing, PEP, PrEP, as well as linkage to care. And it really fosters supportive environments for those living with HIV. And again, I think what the Secretary spoke to, too, is really boots on the ground and empowerment and advocacy. So empowering individuals living with HIV and AIDS to advocate for themselves and participate in decision-making processes about their care and support. can really foster a better sense of control and autonomy. And then social support networks, really creating and fostering support groups, community centers, and online forums can help individuals connect with others feeling these similar challenges. Peer support can really reduce isolation and provide this emotional support. And don't forget, hire people with HIV to provide peer counseling. And then the last two is really mental health, really addressing mental health challenges like depression, anxiety, post-traumatic stress disorder. All of these are vital. And many of these folks have lived through the early years of the HIV epidemic, as Raymond has alluded to, and they've lost friends and experienced shame and isolation. So I think counseling support groups and access to mental health professionals can really improve overall well-being. And then the last one, I think what Emma spoke about, is care coordination. So really these integrated care systems that coordinate between healthcare providers, social workers, mental health professionals, and community organizations can really ensure this comprehensive care and support.
Thank you very much, Dr. Antonio. If I may ask a question, put a question to Tunyi. Tunyi, how do economic factors impact access to HIV/AIDS treatment and prevention, and what can be done to address financial barriers? Secondly, are there successful economic models or partnerships that have improved access to care? Over to you.
Thank you for that question. And really echoing a lot that has been said by the other panelists on the importance of kind of multidisciplinary care, and by the Assistant General, Solicitor General, by the importance of communities and partnerships. So we know that, access, awareness, being able to get access to medications and treatment, being able to stay on, and right, all of those things are really part of the care continuum. So not just knowing of medications, but knowing how to get to them and how to stay supported on them. So economics play a huge role in treatment and prevention in terms of people even being able to access those treatments and stay on them. So economic importance, not just for the medications, but also things like support services around housing and transportation, to be able to get to clinic appointments. And even we talked about decentralizing care so that there can be alternative ways of doing this, using other models of care so that the cost of the care is not just about getting to treatment, but also meeting people where they are. And I think that the Secretary General talked about examples in Namibia and Nigeria where the communities led and figured out where people were and figured out decentralized ways of providing care, because that does add to all of that. The other part of it, if we talk about in the US, is how fragmented our healthcare system is. I think it's been brought up, and how much, even within a certain system, the coverage is very different by patient, by jurisdiction, by geography, by county, which is where the policy and all of those things come into place also. And it becomes important to think about, in those situations, the models that work. I'll give the example of, say, in the US, the Round White Care model, where really more than 500,000 people of the 1.2 million with HIV belong to, are covered by Round White. It's a federal program, but it allows not just the care for the medications and the costs, but the supported services that people need around case management, substance use treatment, and all the other things that help people succeed to stay engaged and retained in care. Because a lot of times when people say people are lost to care, they're not engaged, what are we doing proactively to figure out the social determinants of health and how we can support that? And it's important to know that while economics are important, if you look at the countries that have met their 95 goals, they're not the most resource-rich countries. They would actually be considered low and middle income. So if you look at Botswana, Eswatini, Uganda, Zimbabwe, Tanzania, South Africa that have gotten to there, these are places where there are important partnerships between the government, the NGOs, between the community, and people leading that. So partnerships are really important in terms of the economics. And I think the models of where people come together with like PEPFAR, UNAIDS, public-private partnerships, research and development, working with community, is where you see those examples, starting with the community, but where people are there with economics to be able to figure out not just how to start up a program, but how to scale it up right? And how to share best practices, because a lot of programs live and die with the execution. They're done, and then they're done. Nobody knows how to translate that or to scale that up. So that becomes part of the economics. It's not just the cost of the medications, it's the time minus before when you're in the community, and then access to the medications, the cost sharing and things that happen, the policy people working on guidelines and making sure things are covered, but also supporting people to stay in treatment, because we know that, again, when people are undetectable, they're untransmittable, U equals U is powerful, and that if we put things in place to support people to stay on treatment, it actually makes a lot of economic sense. The right thing to do, but you can do good and do right. So it's important to actually put those in place. And I think the last thing I'll say around the partnerships is, I talked about how countries that are not resource rich have been able to do it, but also knowing that when they're partnerships, they have to be people-centered, and those partnerships have to look at things around having the communities be part of the planning, the execution, the budget, the monitoring, all of those things, and not just kind of an in and out. So there are partnerships that work. And the last one is, more recently in the US, kind of trying to look at what PEPFAR has done and UNAIDS has done, the US Business Coalition to End HIV. That was the first time. It was founded last year, and I think as of now there's 40 organizations in that, really to say that the economics matter. And especially not just in the US, but globally, right? If you empower communities and provide jobs and housing and help people, you can change the trajectory of a lot of things, not just HIV, but other things. So the US Business Coalition was founded last year. Now it has about 40 members in there, but it has people from organizations from pharma, so Viv Healthcare that I work with is one of them, a lot of pharma companies, but it has Walgreens and CVS, testing organizations. It has people that make HIV testing. Uber is on there. So they're all donating their efforts towards empowering the employees, doing employee engagement. More than 2.5 million employees have been educated about HIV. If you think about all these companies, Uber providing support services to help people to get to their clinic appointments, testing and things like that. So the business coalition is coming together to work on the economics of ending HIV, and I think that's really looking about what's happening globally and trying to do that. So lots of examples, but they're centered on people-centered partnerships between different parts of the community, having the communities lead and having them be at the point of all the decision, including implementation, execution, and sharing best practices.
A huge thank you to you, and more particularly, thank you for mentioning partnership, which is very important. And you also mentioned a few African countries. We mustn't forget Africa Agenda 2063. It's very important. Thank you. At this juncture, I'd like to once again shout out to those who are watching us on UN Web TV to use the hashtags, hashtag UN with Civil Society, also hashtag World AIDS Day. I'm now going to turn across and open the floor for questions. I'd like to, first of all, give some few housekeeping. After I select you, you may take the floor by pressing the button next to your microphone. The light will first be green. Once the light on your microphone turns red, the microphone is active and you can speak. Please, if you would raise your hand so I can see you, and we'll get as many as we can on this first round. And also, I'd like to remind you to state your name, the civil society organization, affiliation you belong to, or otherwise. And also, I'd like to remind you of time. Try not to make statements. This is indeed an opportunity to ask questions, and we want to ensure that we get as many as possible. So, ladies and gentlemen, the floor is open for any questions. Thank you. The lady over there.
Good afternoon, and thank you so much for this event. My question is actually for Dr. Kaplan of H&H. I work with the New York City Department of Health, and it seems that H&H and the New York City Department of Health cannot get it together in order to coordinate resources and ensure that access and availability of care is present for all New Yorkers. What do you suggest the city do about that, considering that these two critical institutions need to work together to provide that support?
So thank you for that question. The New York City Health Department and Health and Hospitals recently actually partnered together with some Ryan White Part A funding to do care redesign related to caring for our aging population. So 60% of our about 12,000 patients in our healthcare system are age 50 and above. Geriatric or older is considered to start at age 50 among people with HIV due to accumulation of comorbidities related to the chronic inflammation from longstanding HIV. So part of this funding really is an opportunity for care redesign and how we can best meet the needs for this patient population. We've been working with, in addition to aging, the Department of Aging and SAGE and New York City Health Department, we've been working with our systems geriatric experts to really understand how can we screen for conditions related to aging and prevent what we can and really maintain high quality of life, function and mobility so people can age gracefully where and how they want with dignity. I'm happy to take your email if there's specific complaints or concerns, and I can absolutely look into it.
The gentleman over there.
Hi, everyone. My name is Jay Adewale, and I'm the Executive Director of African Coalition for Development. So I have like 3 questions, and it's in regards to Africa. So I want to know what innovative approaches or technologies are being used to combat HIV/AIDS in Africa. That's the number 1. And number 2 is about the youth. So how can we engage and involve young people in the global response to HIV/AIDS, considering the fact that they are the key population at risk? And the third one is, what steps are being taken to ensure the sustainability of HIV/AIDS programs and initiatives in Africa, particularly in resource-constrained settings? So thank you.
Thank you very much. Is there anybody in particular, would you like to answer that question, Raymond, regarding the youth?
Yes, I'll answer question 2, the youth. So the youth, well, we have to start with health education. We were all invisible at once. We're going to live forever. We're Superman. So we have to mirror the language. We have to slow down with the jargon and mirror our youth. The youth today they do everything, social media. We have to create safe spaces for them. One of the things we have to teach our youth is that today, HIV is not like it was 30 years ago. Today we have serodiscordant couples, which is a couple that is negative and positive, and they're still able to have a wonderful, healthy life and have children and not be born with the virus. So we, talk about serodiscordancy. We talk about U equals U, undetectable means untransmittable. We also talk about comorbidities, co-infection, opportunistic infections, and let them know, that there's, to look ahead in the future. Because the youth today, we're just thinking about now. So especially in the LGBTQIA community, LGBTQI. So they are, people that the youth that I worked with in the last 18, 20 years, and they're invisible. They have the Adonis factor. So we have to reprogram the youth and tell them, I said it before, forget about the myths and let's get into the facts. And last, I stated this, it's very important, very, very important, the jargon. We have to meet them at their level. Thank you.
Thanks very much, Raymond. Rodrigo, would you like to answer question 2?
Yeah, most definitely. I want to add to question 2, especially with regards to African youth. Most definitely want to add on to a question 2 with regards to African youth in particular. It's very, very imperative that we do understand where they're coming from in terms of culture as well. Belief is very, very huge. One of the things we realize is the majority of youths in Africa have access to social media. So that's the first and most important thing. So we can use social media platforms to actually disseminate information, accurate information about HIV management, prevention, and treatment as well. The other thing is actually partnering, with celebrities. We have all these great musicians in Africa. Everybody wants to, so we can actually partner with them. They have a lot of followers, and we can actually use them to use hashtags HIV. That will actually get the youths engaged in the HIV talk as well, and also seek HIV treatment. The other thing is actually getting tailored education. So sex education, which is something that is very, very challenging in Africa, sex education in school, but something that if we actually get the parents involved and give them a reason why we're getting that, that education, it will be very, very imperative that, getting the parents involved in the education session is also very, very imperative. So the most important thing is education, social media, and also getting celebrities involved as well. This would definitely get African youths involved in HIV care and prevention. Thank you.
Thanks very much, Adiga. I believe, too, you would like to answer the next question?
Yeah, I can't remember, but I can do the youth, and then you talked about sustainability, right? So again, just like all the points you mentioned around the youth, but again, also just having them lead that. They know the language, so having them at the table, and a lot of organizations have been able to do things, and even with the research or even in care, have had the youth be part of it. So have them be part of developing the content, the message, have them be the messenger, have them lead peer-to-peer groups, and also have them be the ones that give you feedback. Because a lot of times we think we know what they need to hear, and they need to tell us. And when that has happened, it's worked. And, the ASG talked about Nigeria. I'm Nigerian. And what has happened in terms of just the uptick in prevention. And so just, in the UNAIDS report, next to South Africa, Nigeria, I think, had the highest number of PrEP initiations, right? And more than 500,000 people. And a lot of the initiatives that have been done more recently have been youth and community-led, where they've had increases in people accessing treatment by something like 60%, more than 40% increase in consistent condom use, more than, starting PrEP. So a lot of it is starting by the community, and when it's led by them with the technology, and now you throw in AI, which they're already starting to look at in the music industry, there's ways that can be done to sustain it, especially when it's led, but has to be put in the context of empowering people too. So hiring them, having them with jobs and being part of developing these things, because then it's real, it's personal, and they can see the tangible effects. And then the last part of that is when you talk about sustainability and stuff, if you remember the HPTN, the HIV Prevention Trials Network, 084-1, which was for the adolescent girls in sub-Saharan Africa. Now, that study was supposed to be a small sub-study of the larger one, They actually over-enrolled, they enrolled ahead of schedule. This was in young women, 13 to 17, in sub-Saharan Africa, in research. Done ahead of schedule, they had to end it, showed no seroconversions, but what it did was show that when these young girls, this was personal for them, so they understood what the study was, they recruited their friends, they stayed, there were no drop-offs on the study. I mean, this is incredible. So when youth understand the why, so that's a problem. A lot of times we have the message and they say, this is it. If they buy into the why, then the what and the how and the when, it's about it. So when they get into racial equity and justice issues and fairness issues, once they understand the why, they will be part of helping us develop that content, but also it's personal and it'll be sustained, but we have to also support them to make sure that there's economic empowerment, there's school and all that, especially in parts of the world where in sub-Saharan Africa, more than half of the infections are in young women, in women, 50%. But we know that if you educate and empower women, the community is all set. So we've got to do it.
Good stuff.
Thanks very much to you. I'm also Nigerian as well. Nigeria is in the house. Nigeria Day for house. So, Dr.
Fola, also Nigerian, would you like to?
Another Nigerian. Thank you so much for the question. On the question about innovative ideas that can actually be used for preventions and to aid treatment, you could hear what the ASG mentioned in terms of in community where they're using e-bikes. And it takes us back to one of the points that I actually flagged in terms of what the policy makers can do. If we empower the community, the ideas that we have in the mind of people in the community it doesn't have any limits. I've seen documentaries where there are problems to access to safe bloods, and they were actually using drones to actually carry blood from point A to point B, not in the United States, in Africa, because the people understood their context. They know the terrain. They know what is happening. So if you give them the opportunity, if you empower them, and if you ask them to actually provide solutions, like Tony mentioned, you carry them along during the planning. Just don't make it like top-down approach, bottom-up approach. Like that, they will be involved, they know what it takes, and they will be able to come up with ideas that the thing may actually help to solve the problem that you're dealing with in terms of access to treatment and access to prevention measures. Thank you very much.
So could you wait to the...
Oh, this one? Oh, okay, got it. Hello, my name is Joseph, and I'm from Sierra Leone, West Africa. I'm also the founder of a community-based organization in my country, Sierra Leone. So one of the speakers made mention about the culture being different in Africa, which I couldn't agree more to. So my question is, what thoughtful and better approach should be taken to help tackle to help fight against stigmatization against people with AIDS in Africa, because most people don't take to it well, and they go ahead like committing suicide and losing hope and stuff like that. Thank you.
Thank you very much for the question. I'm African as well, and I visit Africa almost every year. I do have a lot of HIV patients in Africa that I do see. One of the things that I realize when I go back home, the first thing is Africa is considered a spiritual problem. So HIV, is considered a spiritual problem. So that's the first thing. That's the first barrier. The second one is they're still in doubt, that HIV actually exists. And I'm from Cameroon, and we have in AIDS in French is called SIDA. So in Cameroon, we have a way we said it is syndrome inventé par les Américains pour décourager les amoureux. So for those who understand it, it means it's a syndrome invented by Americans to discourage lovers. So that actually is already a problem. So how do we approach this problem? The first thing is to actually let them know that HIV is real. It's not a voodoo problem. It's not a witchcraft problem. Get the community members involved. That's the first thing. The mothers are the most important ones. The church leaders are also very, very important. And also the leaders of the community, like the chiefs. Those are the people that can actually help disseminate this information, the accurate information about HIV. Until we get this community involved and get church leaders involved and mothers as well, then the myth is still going to be there. So the most important thing is accurate information and getting the community involved. I hope I answered your question.
Yeah, thank you.
Right in front of me. It has to go red, yeah.
Hi, my name is Bernard, and I work for Wyckoff Heights Medical Center. My question is, I've heard what Dr. Florian was saying and some of the other providers were saying about the condition in Africa. But one thing I've seen, I've traveled a lot I'm from Ghana, so I've traveled a lot between Ivory Coast, Liberia, Ghana, South Africa, and other places. One thing that I've seen is having something as basic as condom. Ghana, for example, when I tell my friends, condoms over here is for free. They don't like, for free? They don't believe it that condom is for free. So what is the UN doing? What are other organizations around the world doing so that something as basic as condoms could get to the front line where HIV is a serious problem? Thank you.
Right. I work at a federal qualified clinic in Brooklyn, most definitely, and I have some tremendous individuals that have been really helpful in donating condoms. I think it's actually meeting the right people, connecting with the right people, that will get you these things for free. They have organizations that do provide condoms free, which you can actually ship to Africa, where they can have free condoms. So in case you need that information, we're very willing to help you with that. So there are a lot of organizations in the United States of America who are willing to donate free condoms to Africa, as long as it is going to get into the right hands. Thank you.
Dr. Fuller, would you like to ask the question?
Yes. You are absolutely right. Things like condoms should be available virtually everywhere. But if you look at some of the things that I mentioned earlier on, the resources for fighting this HIV epidemic, I remember at the beginning of the pandemic, if you go to many health facilities, you go to some government offices, you will find access to condom for free. But the thing is, when the resources allocated to fight the disease is winding down, then policymakers tend to kind of rationalize on where do they put the fund in terms of what they need to do. So for this, we just need to continue to advocate for support, for funding, especially in terms of providing some of these basic essential commodities that should be available to prevent the transmission of HIV. Because if you prevent the transmission, we won't have the infection. So they are very, very crucial. And there are organizations, I know, UNFPA normally support the Ministry of Health in countries by providing access to condoms for them to use in the health facilities. And I believe with more advocacy, with more empowerment to the community, we may be able to knock the door of the policymaker for them to provide more support, more funds allocated, and even also we may be able to convince the governments. Because this thing also bothers down to the government of the countries that you are dealing with. Because if you are allocated funds to do A, B, C, if there are pressing emergencies, like for example during COVID-19 pandemic, mask. People are looking for N95, condom, so you need to prioritize. So it becomes very difficult for people to prioritize when the funds allocated to support basic essential services are winding down. That is why it's very paramount for us to continue to advocate for more resources, for more funding, especially for developing countries where access to health care and health services are not at par with what we have in the developed world. Thank you very much.
Thank you very much for the opportunity once again. My name is Stephen Kojosaki from Ghana, and I want to also ask a very important question with respect to voluntary testing. Realize that a lot of people, because of stigma, they find it difficult to do testing, and for that matter, they continue the spread within the community. And you realize that some of the hospitals, some doctors do testing at the blind side of the patients when they suspect that there are there is possibility of HIV virus or other infections in the blood. My concern is the ethical aspect of it. If it is unethical or ethical, what are some of the legal guarantees to protect those doctors who do that testing so that this infection do not spread in the community because of the stigma attached to AIDS? I don't know if. Thank you very much. I work with International Association of World Peace Advocates, African Focal Point to the United Nations. Thank you.
Thank you for that very important question. I'm going to try and answer the first part. So I think to combat stigma, it's absolutely crucial that we normalize HIV testing. Every patient or every person, when they're coming in for routine healthcare at any point of access to the healthcare system, whether it's for treatment or for preventative care, that is an opportunity for HIV screening. It has to be treated the same way that we screen for cholesterol or for diabetes. If it's siloed or put into this like niche area, then the stigma and the shame are sort of reinforced. It has to be normalized as part of routine care and really an opt-out approach. So like talking to somebody, say, oh, I'm going to test you for cholesterol and your sugar and for HIV, blah, 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 blah. When it's offered in that way as a normalized routine thing, it doesn't take away all of the stigma, obviously, but it goes part of the way. So I'll leave it there.
Yeah. And just to add to that, I think in order to make what Dr. Emma said is that you need policies within your hospitals that are followed and that are approved by the leadership so that everyone is on the same page and that every patient encounter with someone at that institution meets with that same kind of procedure of this is something that we offer to everybody, that we're not singling you out because of this or that. But it really has to start. This one, I think, does need to be a little top-down, okay? But you need the leadership at that hospital to be in line, and it does mean bringing in the stakeholders and putting together policies and procedures and then training staff.
Yeah, and I completely agree with what's been said, and just normalizing and routinizing those conversations. And like Antonio said, it's really important to understand whatever the policies, like you talked about. But, you talked about Ghana, but it's happening, in the U.S. And part of the fight is, despite since 2006, which was now almost 20 years ago, where the CDC said to do routine testing, we're still at a place where healthcare providers are still not doing it. They're deciding in their mind who they think needs an HIV test. So again, normalizing the conversation. And we think, and we've seen some of the earlier, that U equals U, undetectable equals untransmittable is such an empowering message that's helping with testing. Because the reason people don't test for a lot of times is they're scared about what happens if I have an HIV positive result. What does that mean down the line, right? And for the HIV, the provider also saying, how do I counsel? I don't know. But U equals U says, it's a status neutral. Getting an HIV test is actually the most empowering thing you can do for yourself, right? And that, the whole thing about ignorance is bliss is not true. And what you don't know can hurt you. So that testing early either gets you connected to care, and we have the support to engage and great medications to keep you virally suppressed, or put you on the other side of the continuum where you can go on prevention if you're active. But those conversations have to be rooted in sexual wellness, and they have to be had in a very affirming, safe space, and also routine. So that's really important, because half of the infections we see in the U.S. are in the U.S. South. A lot of that has to do with stigma. A lot of that has to do with provider issues. And so in geographies where there's a high rate of HIV, it's not about the person's sexual health or behavior. They're in a place where no one's talking about HIV. And so all of these things that have been brought up is really important. But the policies, obviously, will have to depend on the jurisdictions and all that. But normalizing the conversation and rooting it in a way that, regardless of the results, there is a plan to engage in care or to discuss prevention options. And that is incredibly empowering for most people.
Dr. Fuller, would you like to?
I like what Antonio mentioned, that this time around it has to be top down. I mean, because it will take me back to the issue of policymakers. I mean, you still need the backings of the policymakers to actually give good legal framework that actually supports and that actually prohibits stigmatization of people that are living with HIV. I mean, when there are issues like punitive measures against people coming out or people going for testing, then those are issues that policymakers need to address by putting up measures that will protect the rights of people living with HIV, people that are at risk of HIV, and people that are actually going for HIV care, irrespective of where they are located, and the laws must be to protect them from any form of discrimination and stigmatization. So as long as we don't have the backing of the policymaker, we may be battling with this back and forth. But once we have the backing of the policymaker, there are legislation supporting the rights of people living with HIV, then, and also the policymakers are actually at the forefront by creating awareness or supporting advocacy for people living with HIV or people going for HIV services or testing, then those are things that we can actually do to actually help with solving this problem of stigmatization and also problem of access to service because of stigmatization. Thank you very much.
I think we'll have to go for the second round of questions from the panelists before we come back again for the second rounds. Thank you. Yes, sorry. Mr. Antonio, how can we engage and educate young people effectively in HIV/AIDS prevention efforts? Are they specific?
I'm Raymond.
Oh, Raymond, sorry. Raymond, sorry. Are there specific challenges or opportunities in reaching and involving youth in the fight against HIV/AIDS?
Challenges today, and I had said this earlier, it goes back to, you know, at a certain age, 18, 19, 20, everyone has that invisibility cape. They're going to be 100, you know, they're on top of the world, feeling healthy. And usually in the last 20 years, I've noticed that some people come in with an AIDS confirmation because they've been accumulating the HIV/AIDS without having symptoms. And then when they come in, you know, they're really sick, and that's when they know, wow, I should have took key to getting tested 10 years ago. And then some people don't have the education. We got to educate the youth, and that's one of the reasons why the kids today, or not even kids, teens and people, don't have the information. Yeah. I didn't even use the mic.
Thanks a lot. Ndigwe, how can we improve public awareness and education regarding HIV/AIDS, especially in communities with higher prevalence rate, and also their successful campaigns or initiatives that have effectively raised awareness and, above all, reduced stigma?
Thank you very much. Yeah, the ways we can actually improve awareness with HIV, there are a couple of ways that can be utilized. One most important one has been talked about, which is community involvement. You know, so having members of the community actually involved in the planning of these educational sessions of this campaign is also very important because they are able to reach out to the communities. The community members are going to believe and they're going to be more receptive to any education from the community leaders. The other one is actually peer education, and peer education is very, very important, especially when we have the youth involved in the development of this educational planning and strategies and interventions as well. As Dr. Tonya said, you know, having them know the why, you know, why are we doing this? What is the purpose of it? What is the essence of it? You know, and actually giving them the opportunity to be part of it is also crucial. Another way of creating awareness is social media. I talked about social media earlier, and we all know how important social media is. We are currently on social media. So using this platform, the same platform, social media, was utilized 40 years ago to actually disseminate information about HIV, which did create some form of discrimination. Because when I was growing up, what I saw on TV where people dying was a death sentence, So using the same platform to let people know that HIV is no longer a death sentence, that you can live, a healthy life, you can have a normal lifespan if you just take your medication. Letting people know that we have preventive measures, we have PrEP, that you can take just one pill a day or take an injection every 2 months is very, very crucial as well. The other thing I talked about was actually getting influencers and also celebrities involved as well. So those are ways that we can help to create awareness about HIV prevention and management. Talking about campaigns that have been successful, there have been so many campaigns that have been successful in actually helping, decrease stigmatization related to HIV/AIDS. One of them is the Zero Discrimination Day, which is actually a UniAIDS one, where the 1st of March every year they do celebrate that to help people, put an end to discrimination. But one that I really love and that I think is the most successful is the U equals to U campaign. And for those who do not know, U equals to U means undetectable equals to untransmittable. And the reason why I love this particular campaign, and I use that every time with my patients, is because it doesn't only benefit the community, it doesn't only benefit the patients, but it gets the patients involved in care. Because the patients get interested and they get very curious. They want to know what is undetectable, because a lot of patients do not know what undetectable equals to untransmitted is all about. So you then have the opportunity to tell them undetectable means that your viral load is so low that it cannot be detected. And they will want to know, how do I get to that point? You see, so you are able to tell them you just have to take your medication as prescribed every day, and then you're able to maintain undetectability. And if you maintain undetectability, your sexual partner is not going to have HIV. You can have a child through normal delivery without the child having HIV. So these are the strategies that I think have been very, very successful. Thank you very much.
This question's for Emma, Dr. Emma. Emma, beyond medical treatment, how can we enhance long-term care for individuals living with HIV/AIDS to improve their overall quality of life? And secondly, what support systems exist in our communities that are crucial for those who have indeed been on long-term treatment?
Thank you for the question. First and foremost, I think we have to really center community and patient voice in determining what is quality of life and what is high quality care. If a system is delivering what the system thinks is high quality care and that's not what is experienced by those who are actually receiving the care, then the mission is not successful. So I think absolutely incorporating at every single step of the way community and patient voice as to what parameters are important for high quality care and for high quality of life. Measuring that objectively with patient-centered outcome measures that really focus on what are the factors that are most important to the community that is receiving the care. I think prevention in terms of high quality of care and high quality of life, there's a term many people may have heard, an ounce of prevention is worth a pound of cure. It is much better to screen for somebody who is at high risk for falls and prevent that fall than to treat them after they've broken their hip and they have a high risk of dying in the next year because of that hip fracture. It is much better to prevent a heart attack than it is to treat the heart failure that results after a missed heart attack. So we can't prevent everything, but preventing what is possible through vaccination, through screening, through engagement in care, through health promotion. It's not just about treating disease after disease manifests, but how do we maintain health? How do we maintain high quality of health? How do we maintain how do we maintain health and people living the way that they want in the places that they want? Another thing that was mentioned by Dr. Nafour before, the social determinants of health. I think it's absolutely critical that we consider the social determinants of health as healthcare. They are not separate. Access to medication is healthcare. Access to food is healthcare. Transportation to a clinic visit is healthcare. If you are trying to prioritize feeding yourself and feeding your family over getting your medication, you're generally going to choose feeding yourself and feeding your family. You're not going to be able to focus on the needs of maintaining a chronic condition or taking medication every day. So we have to incorporate these social determinants of health into our framework of high quality care and address the factors that are making it hard for people to access care, including poverty, including food insecurity, including housing crisis, because that is as important as the actual targeted medicine itself.
Thank you very much, Dr. Emma. Tui, if I may put a question to you. What is the outlook for the future of HIV/AIDS treatment and prevention? Above all, what milestones are on the horizon? And how can the international community work towards achieving the goals set in the fight against HIV/AIDS?
Thank you. And I think I'm going to do this one with my,
Yes, you're
my
doing it.
partner and colleague,
Yes.
Dr. Albina. But so, you know, the future is bright, and we'll talk about that. But I think we both, and we all agree that we have to create a sense of urgency with what we have to date, right? But what we do know, and we've heard from this conversation, is that if it was all just about the medications, we would have ended the epidemic, right? We have the tools, the biomedical tools that we need for treatment and prevention. We've heard about U=U, which is treatment as prevention, right? So people can no longer transmit HIV. That's one arm of ending the epidemic. The other part was prevention or pre-exposure prophylaxis. If that was all that was needed, we would be done. We have PrEP, we have treatment, great treatment options that have evolved over the last 30 years. We have condoms, we have voluntary male circumcision, we have things that work, right? But we're not there yet, and that's because there are things like stigma and poverty and all the isms we talked about, which is why we still have to continue to do that. And we also have to realize that while we've made a lot of progress, and we talked about the great things, in the US, there's still a lot of disparities, right? And you know, of all the infections that are still happening in the U.S., you know, 36,000 new diagnoses, you know, more than half of those are happening in the U.S. South. So there are geographies, right, that are affected. There, you know, more than 60% of infections are people under 30, 13 to 34. We know that 1 in 5 is still in women, of which most of them are women of color. So with the things that we have right now, we have to, as we look to innovation, very important, innovation and research, we have to always be thinking, how does innovation not worsen existing disparities? And we have to be very conscious of that. The communities have to hold us accountable, advocates and policies, because you can continue to innovate and widen disparities if it's not there's an intention behind closing those gaps, and gaps do exist in the U.S. and different parts of the world. What we have now, you know, we've talked about the evolution of therapy and all the treatment and prevention options and injectables and all that. The future looks great. There's more things coming up, and I think in the larger scheme of things, they're falling into longer and longer acting, right? Longer and longer acting medications. Things that are possibly injected outside of the clinic setting, self-injections, you know, things like that. And then just looking at things that just help with quality of life. Beginning to look at that fourth, we talk about the goal of getting people tested, linked to care, engaged and undetectable, but that quality of life metric, right? So beyond viral suppression, quality of life and how people are feeling. So the goals of a lot of the treatment and things looking forward are just the future of, you know, long-acting and maybe self-administration, looking at different modalities and where to do that. But it's important to know that while those research things are going on, and so Antonio has other examples and things, is that we not lose the sense of urgency to really embed the things that we have available and make sure they're getting to the people that need them while we look to the future. So innovation is important, the future is important, but we also have to not lose sight of what we have and how the sense of urgency, because there's still 4,000 new infections every week, and that's not okay. So, Tony?
So, yeah. So Dr. Toyin has made some really excellent points. So I just want to add that I think the big holy grail is cure and vaccine, right? And that's really what the patients want and deserve. We're not quite there. I would say vaccine maybe 10 to 15 years, cure similarly 15 to 20. It's, the science is very tough. HIV is a retrovirus, and it interjects into the human genome. And you really have to kill it everywhere. It hides in this reservoir. So the science is tough. But there have been advances in terms of basic research, and I think we are heading towards that. And that's definitely our goal. But I think what Dr. Toyin said is that we have tools that are available now, both for prevention and for treatment. And it's pretty much similar to what we're seeing in Silicon Valley in terms of these advances. We're getting to that iPhone 14, 15. But I think an important point, too, is that with all this innovation, it's only as good if we're able to implement it equitably, right? So cost, right? Implementation, storage. Does it need cold storage and things like that? So we really have to make sure, and that's where our community advocates are super key in making sure that these innovations are available to everyone. And these innovations are remarkable. So currently now we have long-acting injectables for people living with HIV, and we have them available for prevention. For treatment, they can be dosed every 2 months, the same for prevention. But very soon, they're going to be dosed every 4 months, every 6 months, and we're also looking at possibly having interventions that may only have to be dosed once a year. And I think circling back to stigma is that I don't ever think we're going to completely eliminate stigma. There's self-stigma. But I think that these long-acting injectables do a lot to help. I know with my patients that have asked for long-acting injectables, they said not having to be reminded every day that I have HIV by taking a tablet was very liberating and freeing for me. So again, I think until we get to that holy grail, we have to really equitably implement these longer-acting strategies, both for prevention and for treatment. So I'm very excited about all the potential therapies that are in the pipeline.
I'm going to go for a second round of questions, and if I could please remind you to say your name and who the question is directed to. The lady in front of me.
Thank you. Thank you for the opportunity. My name is Alina Karima Musama. I come from Zambia, and I am the UN Youth Rep with the NGO Committee on Sustainable Development. In my home country, the focus shifted. We have, I think one of the speakers mentioned that Africa is quite a huge pandemic. And so we have many campaigns, we have many organizations. UNIFPA donates condoms as well to Zambia. But during COVID, the data was, perhaps the right word would be miscollected. So there was a lot of information around COVID. There was a lot of campaigns around the coronavirus, COVID, the sensitization, etc. And so we didn't have enough data being collected on M&E around HIV and AIDS, the PrEP, the PEP, how many youth have been infected, how many youth are U equals U. That's a very big campaign in my country as well. And so once COVID kind of subsided in my home country, the focus now was, oh, the numbers have doubled. But in truth, they had not doubled. They just were not being collected. So my concern is, how do we protect this data collection so that we have accuracy on M&E? Data is very important to know if the solutions are working, to know if the young people or people in general are taking the ARVs. Are they U equals U as well? Thank you.
I'd like to answer that question.
Can I go next?
Okay, Doctor.
Thank you so much on this. I think COVID-19 pandemic is like new to all of us in terms of how we're dealing with it, the logistics, and all the things involved. The problem that we faced during COVID-19 pandemic, there were more of the COVID was on our face, and then we find it difficult to actually deal with basic essential health services. So every country should actually have a plan to deal with in face of crisis to ensure that basic packages of essential health services are ongoing. It might be difficult, and HIV/AIDS treatment management, they are part of basic essential health services that should be going on, irrespective of the situation and the condition. And it's quite unfortunate that this happened during the pandemic, and we could all understand because of the issues that we're dealing with all over the world. But the thing, again, we need to ensure that irrespective of what we are facing, we need to ensure that basic package of essential health services they are going on. I remember some years back when I was working in Liberia post-conflict. I mean, it was more of whatever is happening, you need to ensure that access to basic health services are ongoing. And that is what is happening in some of the countries that are actually facing crisis now. It might be difficult, but all stakeholders should try to ensure that access to basic package of essential health services, including data collection, documentation, they are ongoing during a crisis. It might be difficult. We may not get the perfect picture, but at least we need to put in the effort to ensure that we're able to get all those basic services going on to people, irrespective of the type of public health crisis or challenges that we are facing. Thank you. Oh, Tony, I think Tony, you want to say something on this also.
Yeah, no, thank you, Dr. Paula, and thank you for that excellent question. And you talked about Zambia, but that same thing happened in the U.S. And so during the time of COVID, there was underreporting. It seemed like we had such it's like maybe there was a lower number of cases, and then it went up. And so, and when post-COVID, they saw, rates of viral suppression were off. People were no longer as engaged in care. Testing was happening, but mostly in the setting of ER settings. So there were people who were being diagnosed with acute HIV who were coming in thinking they had COVID. And so some of those places now set up rapid HIV and rapid COVID testing. But the routine healthcare and the rapid testing in the field, those weren't happening because resources were diverted, healthcare teams were diverted. So the data kind of dipped, and there was the upside of some of that was that, with telehealth expanded during that time, and that has still continued to be a model of care both for treatment and prevention. So with those crises or things that we don't know when the next pandemic is going to be hit, how that affects the infrastructure for other existing services, the reporting, and like you said, the data are so critical to be able to figure out what's working, what needs to be scaled up, what is not a go anymore. And when that gets disrupted, it really does affect kind of the planning. But it was, I can bet you, almost every country, and definitely here in the US where we were, there were definitely cases where the CDC the numbers were off. It seemed like things were going down. And then the caveat was the number of tests was just much lower. So the denominator was lower, the new cases were lower, but it was because there was a dip in testing and the diversion of resources. But again, kind of the public health infrastructure of planning for that next crisis, because we don't know when that's going to be. It could be anytime soon.
I believe, Dr. Emma, you'd like to answer that question.
Yes. Well, my colleagues stated it quite well, but I think what you alluded to, the COVID pandemic really highlighted we are a global community. Disease does not know borders, especially infection. Infectious disease does not know borders. We need to have a global public health infrastructure so that if we are hit with another global pandemic or if a region of the world is in crisis, then we can rely on this infrastructure where we can collect data and do surveillance and do contact tracing so we can treat it as a global problem with a global solution. And I think that was one of the key things that's been mentioned by my colleagues that was highlighted during the pandemic. If we don't have a global response, it's not going to be successful.
The gentleman, could you state your name, please?
hold on. I think the mic is slipped. Hold on. Is it working now? Just use this one here. Just use this one. Oh, is it working? Oh, okay. Okay. Hi, so my name is Jason Zhu, and I'm a high school senior from Rutgers Prep. I'm the founder of a biotech startup centered on artificial intelligence and biotechnology. And taking it from that perspective, my question is, how can novel technologies like AlphaFold and generative AI early identify HIV and AIDS and other diseases like that?
I say, you tell us. I have no answer. So when you said high school, founder of a startup, I was just like, oh my gosh. And when we talked about partnerships and you being the Y on AI, and so for the first time when we were at the Infectious Disease Society meeting a couple of months ago, they had a plenary on AI for infectious disease physicians, right? And we're all like, and talking about where they could use it and where it's been most mature. And the most mature was in maybe it could help us with billing and coding and help with some of that workflow stuff so that clinicians can actually do the work they need to do and not do that back end. But there's a lot of applications that, I don't know, my age demographic, I'm gonna try, but you need to tell us how.
Could you turn your mic on, please? Because we can't hear you.
Right, my first time at the HQ. Does this work now?
Yes.
Oh, okay. There you go. So the whole room can hear me? Okay. But yeah. So I guess like a part of that answer would be using these technologies. I mean, you're right. Like our generation is going to be the future eventually, right? So part of that is, I think, using these generative AI technologies, you can help. AI is very good at identifying patterns, right? So actually, a recent paper I read was using artificial intelligence technologies to identify kidney diseases. And that one was a research done by a University of Michigan professor. And essentially, they trained a artificial intelligence model on recognizing the pattern of DNA, so like the structural blocks inside that builds like genes, right? And they linked certain genes with a certain pattern, or rather, they linked multiple genes, like with like a pattern of expression in that kidney disease. I kind of forgot the name, so my apologies. But I'm thinking that maybe something could be done similarly for HIV and AIDS, and I'm wondering that if there has been any progress on that.
Yeah, so you're hired. No, I think where regenerative AI, where I think some of the stumbling blocks have been where, like we've had these vaccine trials that have failed, and there's been just so much time that has gone by. If we can, at a molecular level, maybe identify vaccine candidates that are more effective, you know, and to shorten these kind of trials. So I think using AI maybe to help us with some of these immune-based therapies, recognizing interventions that may be more effective, and this looking at and maybe redesigning our kind of clinical trials and efficacy trials. So if you could have that on my desk by Tuesday.
Emma, I believe you'd like to say something, Dr. Emma.
Yes, I do think there's potential from a less molecular and more population-based level. I think we know the risk factors for HIV, so screening populations of people, whether it's a health system or an individual clinic, say who's a good candidate for PrEP. That's something we've done within our health system. So like, how can providers or clinical teams flag a patient who's had a bacterial STI in the past year, and then communicate that to their care team so it could be brought up at the next visit proactively to say, hey, you're a great candidate for this prevention measure. Do you even know what it is? So sort of using AI in that pattern recognition setting. I think also there's more movement towards not using stigmatizing language in the EHR and how we describe our patients, which seems obvious, but I think is still quite problematic. And so I think using AI that can rapidly review multiple EHRs and come up with, like the electronic health record, come up with these patterns of what are commonly used stigmatizing words and what are natural places for replacement, I think are 2 points that would be very good potential uses of AI. I would say I hope and trust that you'll have an equity lens with AI, because AI, the data systems it's based off of and validated are only as good as the inputs. And so there is the risk with any new technology of like widening disparities or sort of widening the technology gap. And so really having caution and a clear focus and equity lens as you're designing your programs. But very excited to have you here.
Thanks very much. I believe the gentleman in the white shirt, please.
Okay. Hi, my name is Alpha Diallo. I am a youth representative for UNDA, it stands for Environmental Development for the Third World Country. They're based in Senegal. So the question that I have is that what your experience today, what will you like change like if you go back in your journey, or what can you do the same thing again for all of you, the panels? That's the question I have.
Would you like to take it first, Ndige?
Thank you very much for the question. First of all, I won't take it that far because I was still a child back then. That was 40 years ago. Yeah, I was maybe 4 or 5 or something. But, living through the HIV pandemic and actually being a clinician, my main thing is actually the discrimination and the stigmatization, which I think media was one of the things that actually, I think, propagated HIV discrimination and stigmatization, most definitely. The reason why I say that is because, as I earlier mentioned, growing up in Africa, all I saw on TV were people dying. All I saw was just this negative information about HIV. There was nothing positive, and that has actually stuck with people till today. The older generation still have the HIV stigmatization because of what they watch on TV, because of what they were told about HIV. So if I would actually go back in time, what I would do is actually give a different information about HIV, educate people more about what HIV is, give them more accurate education or information about HIV. This will actually help to decrease stigmatization and actually get people involved in care. That's what I think I would do. Thank you.
Dr. Fuller, would you like to say a few words?
I think if I have to go back in time, the area that I will try to address will be more in terms of access to the antiretroviral therapy. It took us a long time before we were able to achieve the current state in which we are now. I believe if we had had access, or we have supported innovative ideas, research and development to support the scientific body to come up with effective antiretroviral agents, the number of people that have died of HIV as of today, we will have actually, if not, we will have maybe like half them, like 50% reduction. So I will more or less try to also to support communities, because that is where we're at today. Everything starts from the communities, and let's give the community, let's empower the community for them to be able to provide solution to the problem. So if we are able to do this, I believe we will have actually have the mortality and the morbidity of HIV that we're dealing with now. Thank you very much.
Sorry, the lady, could you say your name, please, as well?
Perfect. Hi, my name is Mel Gonzalez. I am the outreach coordinator for Montefiore's AIDS Center. My question is here. We place such an importance on peer advocacy and outreach work, both within in-person and social media settings. Yet the reality of these roles are that they are often underpaid with little room for growth. What steps are being taken to systematically sustain and grow programs that engage with the community so we can effectively employ and retain employees that fall under these priority populations, especially those who are living with HIV?
I think I can.
Could you speak a bit loud, because we couldn't really hear you?
Oh, my bad. I said we place such an importance on peer advocacy and outreach work, both in person and on social media. Yet the reality of these roles are that they are often underpaid with little room for growth. What steps are being taken to systematically sustain and grow programs that engage with the community so we can effectively employ and retain employees that fall under these priority populations, especially those who are living with HIV?
So I think I can answer that. Well, one of the things, most New York City Health and Hospitals, organizations around New York City and around the world, they do hire peer advocates, outreach specialists, patient advocates. The problem is when they have a position open, no one has the education. They have to play the part and go out and get, what the companies need, an associate's, a bachelor's, and keep building. So one of the things I encourage the youth, peer advocates, patient navigators, outreach specialists, is just that it sounds cliche, but just keep focusing on your education and everything will fall into place.
Yeah, thank you. And I have a follow-up to that also is the point well taken around opportunities to grow and develop within organizations. So examples within like health systems in Chicago, and also as part of the Getting to Zero plan for Illinois, I was co-chair of that developing a state plan, was a vital role of peers and community health workers, and that was a key point around education support and empowerment with certifications to allow for job opportunities for growth. Right. Because the retention rate was low because of, again, compensation and quality of life. And so when people were engaged and embedded in and played such a key role in improving patient outcomes, it was really important to actually support them and have them have a career trajectory within organizations. So as part of our state plan when I lived in Illinois, that was a key part of community health workers and other peer educators and navigators to have opportunities for career progression by helping with certification, volunteer and different things so that they could do that. And I think the last part of that is also knowing that when that happens, then people are able to engage in and do that work and stay within HIV, because the workforce is changing rapidly, and decentralizing care and having different parts of the system. There are engagement models where they're trained community health workers to deliver antiretrovirals, to do different things. And even here in the US, from Whitman Walker Clinic, Dr. Patel and her group trained community health workers to do injectable treatments and actually trained them, certified them, did the policy top down, made sure it was okay. But really thinking about changing the job descriptions for people, expanding for people's roles, and compensating them for that. So it really is important to be able to keep and retain our HIV workforce and to attract people into the work. So very valid point.
Thanks very much to you. Sorry, the gentleman over there.
Yes, good afternoon, and thank you for giving us this opportunity to be here today. My name is Sam Shade. I'm founder of a couple organizations in USA and Africa for development and human rights. So my question is, in the Middle East and North Africa, talking about AIDS and HIV, it's almost crime. And so what's make it very difficult for the organization to do their jobs. So my question is how United Nations and the international organization can help local organizations to do their job. That's my question, and thank you.
Would you like to answer that? Any takers here?
UN question.
That's a UN question.
Talk to the UN.
Doctor, follow over to you.
So thank you so much for asking this question. I mean, having worked in different contexts, I wouldn't want to mention the name of some countries where I've worked. I have to be screened for HIV before I could be given the resident permit to stay in the country to work. And also, there are contexts or countries where you go that you cannot even talk of HIV. And then you are talking of treatment and prevention. It's almost impossible. So this takes me back to what I mentioned earlier during one of our earlier discussion, which is advocacy and dealing with policymakers to actually discuss, negotiate with policymakers in some of these contexts and countries that we're talking about. I mean, one of the things that we need to address legislation around HIV treatment and preventive measures and strategies. So it's a political thing. And there has been a lot of discussions at different forums where the United Nations have been involved, discussing with all different policy makers and stakeholders. It's an ongoing effort. I mean, what I can tell you is there are countries that have very restrictive law before. Now, with the awareness, with advocacy, some of the measures have been relaxed. Some of the measures have been completely eliminated by the same country after a lot of advocacy and effort to discuss with them that this is actually a reality. People are dying in their millions, and if we don't do anything, if we pretend that HIV doesn't exist in our community, it's like we are living in some kind of paradise that doesn't exist. So some of the government and stakeholders have been able to relax some of these restrictive measures. So how we can help is by continuing to create advocacy around this restrictive law and also engaging policymakers so that they can actually discuss and find ways of actually helping us to solve this problem by talking to other stakeholders and government and also in forum like this, like at the United Nations, to discuss things that we can actually do to ensure that everybody, irrespective of where they are located, they will have access to all the preventive measures and the treatment that are available. Thank you very much.
So the gentleman. No.
Good afternoon. My name is Jae-Suk Singh. I'm 16 years old and a director of Status Health International, a youth-led organization promoting global health equity and literacy with over 2,000 followers and volunteers worldwide. Thank you for this opportunity to speak. My question is as follows. Are there any specific initiatives focused on supporting employment and income stability for individuals living with HIV to enhance their ability to afford treatment?
I'd like to take that question, Roman.
Are you talking about opportunities to become a patient advocate, a peer advocate, or outreach specialist?
For specification, any opportunities or initiatives that would detract from the restrictions that people are faced with when attempting to search for treatment or resources that might help them with their treatment?
Well, my go-to guy is 311, as far as for jobs and treatment and stuff, so you might want to go there. And or, the NDRI, National Developmental Research Institute, GMHC, and all those organizations, you might want to link with them. I'll give you my card at the end of this, and then we'll connect. Okay.
In terms of services available for patients who are HIV, I would talk about New York City. New York City has some great programs that actually really help patients who are HIV get on their feet, if I can say that. They have things like HACA that helps them with housing, so they're able to pay for your housing until you get on your feet. They actually give them cash assist, which is very, very important as well. And for those undocumented, we have what they call ADAP, which actually help with medical services. So you have your medication, linkage to care as well. And the ADAP is not limited to HIV positive patients. We also have ADAP for PrEP patients as well. So if you're looking for HIV preventive measures, we do have ADAP for that, irrespective of your immigration status. So New York does offer a great ton of resources for people who are HIV positive. Thank you.
No, I think what we're hearing here is the importance, and maybe we just don't know, of some kind of, in terms of best practice sharing site or something federal where, not just in your local jurisdiction, just like we have locators to find different things. And so again, as we think about AI and other ways, because there are lots of best practices that are siloed in different counties and jurisdictions that other people are not aware of. And instead of reinventing the wheel, the opportunities to do that. And the gentleman that was talking about the laws and some of the issues, within the U.S., there's so much, and that's why every organization that is in this field of HIV has to have a government relations policy group, and VIV does, where literally they're going county by county, looking at laws and policies, and there's a lot of things happening in the U.S. that are undermining the progress that's been made over the last 30 years, right? With funding, different states and different laws and things that are happening within the U.S. So it's important for us as advocates to be aware of what's going on around us and kind of meeting with our community members and having them understand that and really working with the policy people around the state and in cities, or even sharing best practices of how people have successfully protested something, right, to be able to take that back. And that works with that. But there's a lot happening even within the U.S. where across state lines, different laws exist that actually undermine some of the work that are being done already.
And thanks very much. I'd like to go across to Ms. Hawa Diallo. I'd like to first and foremost say a huge thank you to Hawa, that without whom this meeting would not have gotten off the ground. To thank her for her dedication to civil society and also her team, and also to Catherine Chen.
So I don't know if this is
Hawa,
on.
the floor is yours.
Hello. I'm loud enough. Usually I don't like to take the floor unless I'm sitting on the panel, but I have to say, I mean, I'm really emotional about this session. I've been saying it for a while because it's a session really that I've tried to organize for the last 2 years. We were interrupted by the pandemic. We were interrupted by what is sometimes seen as higher priorities, but I stuck to my guns because I really felt this was I'm gonna get emotional now, I'm sorry, I'm a sappy person. But I really felt it was an important discussion that we need to have. And again, I've heard a lot of people that come from various cultural backgrounds and contexts. And I myself am from Sierra Leone. I don't know what happened. The West Africans have taken over here today. But it wasn't intentional. But I mean, I come from a society where we do not talk about trauma and issues like HIV/AIDS. And I personally, as my family, in my family, have been impacted by AIDS. I'm very much aware of the condition, the situation, the negatives, the positives of family coming together around this disease. So I felt it was very important to bring this to the UN. And I want to thank really the panel members here because I have been moved. I've been so emotional and so inspired. I've learned a lot from what you have spilled out for us here today. I want to thank UNAIDS, of course. We had the Assistant Secretary General here. She specifically came from Washington, D.C. to be with us here today. That is a big deal at the UN. So I really want to thank UNAIDS and my colleagues from UNAIDS who I've worked with for many years and for the work that they continue to do. Of course, civil society. I mean, I'm a civil society person. I've worked in the UN for 37 years. I know I look like as if I just got out of kindergarten. But my heart and energy is with civil society, and I think there's so much value in the work that civil society does. I want to give a shout out to all the young people. These are young people that I work with, because I want to say that they have schooled us. I've just been impressed in the questions, and they're not making it up. Yeah. He is the director and the founder of that startup. So, I mean, with that, I want to think that, you know, the world is in good hands. The Sustainable Development Goals, health issues are in good hands with civil society and especially the current and future generations. I want to thank my team also because I have been like a mad woman. Crystal Frisella, Swati Dave, Stephanie Cardi, Jessica Wren, because this has really been a labor of love. And, you know, I'm happy with the conversation. I wish that these type of conversations could really draw more people. I hear that this is a niche topic, but I think it's a niche topic that we need to explode everywhere, and that we need to have this conversation, leave this panel, this podium, which was so inspirational for me, and bring it out there to the community. Again, with the topic of World AIDS Day 2023 being, you know, communities leading, let communities lead. We really have to put this in the right perspective. So really, thank you so much. I just couldn't leave without really expressing my gratitude. And lastly, this session was actually inspired by somebody by the name of Soare Kamara. I don't know if I'm going to be fired by the UN, but he's my younger brother. And I listen to him all the time about the work that he does on HIV/AIDS and the interesting people that he works with. So I think that I really want to thank you, Soare, for waking me up, for enlightening me, and really making me understand that this is a topic that we need to bring to the United Nations. Thank you so much. And thank you to our distinguished moderator, Igoji. Over to you, Igoji.
A huge thank you. I'd like to thank everybody who's attended this event, more particularly the distinguished panelists, the speakers. We've learned a lot, or at least I can say I've learned a lot about HIV/AIDS. And as I said before, I'd like to say a huge thank you to my sister, Hawa, or we won't be here today. Ladies and gentlemen, as world leaders continue to strategize on how to build back better from the impact of COVID-19, it is indeed imperative that we do not let short-term pandemic measures prevent us from addressing the longer-term needs in treatment and prevention of HIV/AIDS. Ladies and gentlemen, over the past 2.5 years, the colliding AIDS and COVID-19 pandemics, along with economic and humanitarian crises, have indeed placed the global HIV response under increasing threat. I, for one, believe that today we have deepened dialogue amongst the participants and also the audience and critical stakeholders and development partners on how to maintain resilience to the unmet needs of treatment and prevention in HIV/AIDS. We have indeed synthesized views expressed by the participants, and I believe present the key findings as possible policy recommendations for mitigating the unmet needs in HIV/AIDS treatment and prevention in socio-economic life-wise of communities globally. Ladies and gentlemen, the key words or hashtags which I've taken away from here will be hashtag community, hashtag partnerships, hashtag dialogue, hashtag kindness, which I believe we should say in kindness. Finally, ladies and gentlemen, I'd like to encourage civil society to join the civil society unit for conversation with the President of the General Assembly and the 2024 UN Civil Society Conference planning on the 12th of December. Ladies and gentlemen, a huge thank you. I am your moderator, Ugoji Adanma Eze. Thank you.